Hello, future healers. Imagine a young woman walks into your clinic. She is anxious, losing weight despite eating well. Her hands tremble, and she says her eyes feel like they are bulging. Her heart is racing, and her thyroid is visibly enlarged. You are already thinking, is this just anxiety, or is her immune system playing tricks on her? Welcome to the fascinating world of Graves' disease, one of the most classic examples of autoimmune pathology and endocrine disruption. Today we are going to explore how the body's own antibodies can mimic hormones, leading to an overdrive of metabolism, and how this connects to what we see in the clinic, the lab, and under the microscope. We will break it down step by step from the pathogenesis involving TSH receptor antibodies to the morphological changes in the thyroid and the clinical implications you will encounter in the real world practice. By the end of this session, you won't just remember Graves' disease, you will understand it and recognize its fingerprints in both pathology slides and patient symptoms. So let's get started. Students, we will begin with the thyroid key anatomical features first. To understand the entire story of thyroid, we need to understand the anatomy of thyroid first. So it consists of two lateral lobes, one on each side of trachea. There is a connecting band of tissue bridging the two lobes, which is known as isthmus. This gland is positioned inferior to the thyroid cartilage of the larynx, typically corresponding to vertebral level C5, T1. Gland is encased by a true and false capsule with loose connective tissue allowing for movement. There are four parathyroid glands, two on each side, and are located on the posterior surface of thyroid lobes within the thyroid capsule. Now the normal histology. To understand the pathology, we must understand the normal histology of thyroid gland first. It is covered by dense irregular connective tissue capsule. Here you can see pink colored line. This is capsule. Septa extending into the gland from the capsule divide it into lobules. So here you can see trabecular septa. So this is dividing this gland into lobules. You can see big circles, and inside these big circles are small ones. So these big circles are called as lobules. Each lobule is seen to be made up of an aggregation of follicles. So you can see these small circles, these are follicles. Each follicle is lined by follicular cells that rest on a basement membrane. Follicle is filled with homogeneous material called colloid, which appears pink in hematoxylin and eosin stained sections. So inside these follicles, you can see these pink colored structures. These are colloid. There are also C cells or parafollicular cells. These intervene between the follicular cells and the basement membrane, and also between the follicles in the connective tissue stroma. Now this is a microscopic picture of thyroid follicles. Here you can see these circular diagrams. These are follicles and lined by epithelium. Inside these follicles, there is pink colored structure called colloid, and between these follicles into the stroma, there are parafollicular cells. You can see this highly active follicle diagram. This is lined by tall columnar cells and scanty colloid. Then you can see this moderately active follicle, which is lined by cuboidal cells and moderate colloid inside it. And there is an inactive follicle which is lined by squamous cells with abundant colloid. Now let us begin with the point of discussion, that is Graves' disease. It is also known as Basedow's disease, primary hyperplasia, exophthalmic goiter, and diffuse toxic goiter. There are triad of features: hyperthyroidism associated with diffuse enlargement of the gland, infiltrative ophthalmopathy, and localized infiltrative dermopathy, sometimes called pretibial myxedema, present in minority of patients. Peak incidence is between 20 and 40 years of age. Women are affected as much as 10 times more frequently than men. Now we will see the clinical features. Patients are usually young women who present with symmetric moderate enlargement of the thyroid gland with features of thyrotoxicosis, ophthalmopathy, and dermatopathy. Ocular abnormalities are lid lag, upper lid retraction, stare, weakness of eye muscles, and proptosis. In extreme cases, the lids can no longer close and may produce corneal injuries and ulcerations. So students, you can see this first diagram of ocular abnormalities. You can see bulging eyes, then eyelids retraction and redness into these eyes. Next is dermatopathy in Graves' disease. Most often consists of pretibial localized myxedema in the form of firm plaques. So this second picture shows dermatopathy in Graves' disease. Like in Hashimoto's thyroiditis, there is no increased risk of development of thyroid cancer in Graves' disease. Etiopathogenesis consists of genetic factor association, HLA-DR3, CTLA4, PTPN22, a T cell regulatory gene. Autoimmune disease association may be found in association with other organ-specific autoimmune diseases. Hashimoto's thyroiditis and Graves' disease are frequently present in the same families, and the two diseases may coexist in the same patient. Other factors include emotional stress and smoking. Etiopathogenesis consists of autoantibodies. TSH receptor autoantigen is the main antigen against which autoantibodies are directed. It's not quite clear what stimulates B cells to form these autoantibodies in Graves' disease. Possibly intrathyroidal CD4 plus helper T cells are responsible for stimulating B cells to secrete autoantibodies. Thyroid stimulating immunoglobulin TSI binds to TSH receptor and stimulates increased release of thyroid hormone. Thyroid growth stimulating immunoglobulins TGI stimulates proliferation of follicular epithelium, and TSH binding inhibitor immunoglobulins TBII inhibitory to binding of TSH to its own receptor, depending upon its action as inhibitory or stimulatory to follicular epithelium. It may result in alternate episodes of hypo and hyperthyroidism. Activated CD4 helper T cells secrete cytokines which stimulate fibroblast proliferation and synthesis of extracellular matrix proteins, glycosaminoglycans, leading to progressive infiltration of the retroorbital space and ophthalmopathy. The protrusion of the eyeball, exophthalmos, is caused by an increase in the volume of the retroorbital connective tissues and extraocular muscles, which occur due to marked infiltration of connective tissue by mononuclear cells, which are predominantly T cells, inflammation, edema, and swelling of extraocular muscles, accumulation of extracellular matrix components, specifically hydrophilic glycosaminoglycans such as hyaluronic acid and chondroitin sulfate, increased number of adipocytes which cause fatty infiltration. These changes not only displace the eyeball but also interfere with the function of the extraocular muscles. Morphologic features. Grossly, the thyroid is moderately, diffusely and symmetrically enlarged and may weigh up to 70 to 90 gram. On cut section, the thyroid parenchyma is typically homogeneous, red-brown and meaty, and lacks the normal translucency. So now comes the important part of this topic, Graves' disease microscopy. There is considerable epithelial hyperplasia and hypertrophy, increased height of follicular lining cells, and formation of papillary enfoldings of piled up epithelium into the lumina of follicles which are small. So in this line diagram, you can see these circular figures. These are follicles. Okay, these are separated by stroma. All right, and these follicles are lined by epithelium. So we can see this pink colored structure inside these follicles. This is the colloid, which is deficient. Then there is epithelial hyperplasia. That means there is increase in number of epithelial cells which are lining these follicles, and there are papillary enfoldings. Papillae formation without fibrovascular core. Now students, please pay attention. Presence of the latter is the differentiating feature of papillary thyroid cancer. Colloid is markedly diminished and is lightly staining, watery and finely vacuolated. Stroma shows increased vascularity and accumulation of lymphoid cells. So this is the real microscopic picture of Graves' disease. Here we can see there is epithelial hyperplasia. Okay. Then this pink colored structure, you can see this is colloid and this is vacuolated. All right. And these follicles are separated by stroma, and these stroma are infiltrated with lymphoid cells. These blue colored dots you can see, these are lymphoid cells. Alright students. If a patient receives preoperative therapy, it will alter the morphology of the thyroid. Like administration of iodine will cause involution of epithelium and accumulation of colloid by blocking thyroglobulin secretion. Treatment with anti-thyroid drug propylthiouracil will exaggerate the epithelial hypertrophy and hyperplasia by stimulating TSH secretion. Now, what are the changes in extrathyroidal tissue? What is extrathyroidal tissue? That means tissue which is present outside the thyroid. Okay, so there is lymphoid hyperplasia and there are changes in heart. Lymphoid hyperplasia, especially enlargement of the thymus in younger patients, and the heart may be hypertrophied and ischemic changes may be present, particularly in patients with pre-existing coronary artery disease. Alright students, let's take a moment to wrap up what we have learned today. Graves' disease is the most common cause of endogenous hyperthyroidism, which is characterized by the triad of thyrotoxicosis, ophthalmopathy, and dermopathy. It is an autoimmune disorder which is caused by activation of thyroid epithelial cells by autoantibodies to the TSH receptor that mimic TSH action, thyroid stimulating immunoglobulins. The thyroid in Graves' disease shows diffuse hypertrophy and hyperplasia of follicles and lymphoid infiltrates. Glycosaminoglycan deposition and lymphoid infiltrates are responsible for the ophthalmopathy and dermopathy. Lab features include elevations in serum free T3 and T4 and decreased serum TSH. Radioiodine scans show a diffusely increased uptake of iodine in thyroid. So students, from the bulging eyes to the tremors, from the tall columnar cells on histopathology to the suppressed TSH on lab reports, it all comes together to tell a story that every good clinician should recognize. As you move forward in your medical journey, remember, pathology gives you the lens to see beneath the surface, to connect symptoms with cells and lab values with lesions. That's the mark of a sharp and empathetic doctor. Thank you for your attention today. Keep questioning, keep connecting, and most importantly, keep caring. See you in the next class where we will dive into another fascinating condition and get one step closer to becoming the doctors our patients need. Thank you. Bye bye.